My name is Dr. Jeremy London. I am a board-certified cardiovascular surgeon, and I have been in clinical practice for the last 25 years. Today's episode is going to be centered around the treatment for heart disease. In previous episodes, we reviewed anatomy, disease processes, and diagnosis, and now we're going to jump into the treatment portion. So let's think about treatment in general first, before we center on heart disease specifically. And this can be very broadly applied. So essentially, it boils down to this. When physicians are making decisions and recommendations about treatments, it's essentially about weighing the risks versus the benefits of every decision. Even taking a simple aspirin has risks associated with it. And so we have to determine where patients are on that spectrum with regard to individual therapies. Obviously, if the risks outweigh the benefits, then you're making the wrong decision. We always want to stack the deck in the favor of the patient. So where does this data come from? How do we ascertain this? How do we make sure we're doing the right thing? Well, in its purest form, there is a huge body of growing research that specifically involves double-blinded, randomized human studies with clinical controls that help us then determine, based on the outcomes of those studies, what is best in different clinical situations. Now, there's a lot of different research protocols, but I'm giving you kind of the level one, highest quality data that we like to really hang our hat on when we're making difficult decisions. And out of the data, and all of it combined, meaning all of the different levels of data out there and interpretation thereof, come protocols and clinical care pathways that help us then make decisions for a given patient in given situations that they present with clinically. And that's what helps us determine whether or not we are going to go down road A or road B, and what the pros and cons are each of those decisions. Now, clearly, medical research is a rapidly evolving process. There are things that I do today that 10 years ago I did very differently, but based on advancements in technology and new information, we have shifted. How do we handle this? Well, you can only make decisions based on the information that we have today and take care of patients to the best of our ability. Now, all of this sounds great, and it sounds very scientific and very easy to apply, but the reality is none of this is happening in a laboratory or in a vacuum. It's human beings. And I heard Mark Hyman once make reference to the concept of the human body is both complicated and complex. Well, what do we mean by that? Well, complicated is when you can define something very clearly and explain it with a mathematical equation, like, for instance, sending a rocket to the moon. You have to calculate the escape velocity from gravity, how much power that takes. Once you get beyond that, then you can figure out the distance to the moon, and you can calculate that and know exactly how to get there. That's complicated, but it's easily computed with the right information. Complex is more like an ecosystem. It can't be explained with one single equation or one definition. And the reality is the human body is both of these things. There are certain aspects that are easily explained through physiology equations and biochemical reactions and things of that nature, but there's many others that are very, very complex. So in the end, there are no magic paper clips in medicine that fit every single stack of papers. And so the protocols then are really guidelines. And a very wise critical care physician said to me years ago that the protocols are the practice of medicine, But knowing when to apply, and more importantly, sometimes when not to apply those protocols, is truly the art of medicine. So how does all of this information apply to you as the patient? Well, at some point before a procedure, an operation, or starting a treatment with medication, you're going to have to sit down and have a conversation with the physician regarding informed consent. Well, what is informed consent? It's what's wrong with me? What are you going to do about it? What does that mean for me? What are the risks of that decision? What are the benefits of that decision? And what are my alternatives? Now, I prefer to call this process educated consent, not informed consent. And I think that this conversation can really be the cornerstone of the physician-patient relationship. I think it's the physician's responsibility to educate patients and their families with full transparency regarding all of those aspects prior to going in to a procedure or a surgery. Now, why is this really important? Well, it doesn't make an operation any less scary. But what it does is it allows patients to be educated so that they can feel comfortable that they're making the best decision for themselves. So you're not actually trying to talk patients into or out of an operation, but collectively coming to an agreement that road A versus road B is what ultimately is going to minimize the risks and maximize the benefits. So to distill this down just a little bit further, and from a surgical perspective, which of course is what I can give you most comfortably, there are basically three reasons to do any operation on any person. Broad categories. And this is something that you may want to keep in mind when you are having conversations with a physician about a procedure or an operation to see which category you may fit in. It's just helpful to figure out which bucket you land in as far as making decisions about your clinical course. The three categories are as follows. You're dying, or a patient is dying, and you need a life-saving procedure to change the course of the disease process. Not a difficult situation to decide if the risks outweigh the benefits. Clearly, if it is a mortal situation, choosing an operation becomes very easy. The second is symptoms. Now, symptoms fall in two categories. They can be warning signs of something bigger to come, or that symptoms have progressed to a point that your quality of life is so unbearable that you would be willing to accept the risks of an operation to improve the quality of your day-to-day existence. And so those two categories are fairly easy from a patient perspective to make a decision and from a physician perspective. The third, and this is the one that things can get a little more difficult with, is you need to change the course of the natural history of whatever disease process you're being evaluated for. Let me give you an example. Like you have a leaky valve. It's not causing any problems right now, but we know with near certainty that over the course of X amount of time, this process is going to continue to get worse, the symptoms are going to get worse, and potentially get you into a dangerous situation. So while you are still relatively healthy and the risks of an operation are fairly low, it's better to intervene before you get to a place that the natural history of that disease process has progressed to a point that maybe the risks of undergoing a procedure actually outweigh the risks of doing nothing. And this is a very tough category for patients. Why? Because most of the time they feel fine and something has been picked up on a test or a physical examination or some laboratory test or something of that nature, but they don't have any signs or symptoms that anything's actually wrong. And making that leap for yourself or for patients in general can be really, really tough. So as we go through the treatment of heart disease today, I want you to keep these basic tenets in mind, that our framework comes from research. Research helps us to develop protocols. The protocols then allow us the framework that we use at the bedside, and with conversation and history and physical examination and laboratory data and discussion with colleagues, whatever it may be, we then decide, do you fit in a particular protocol? Is this an appropriate course? Is it two protocols? Whatever it may be. Again, to use those as guides to determine the best clinical decision for you. We'll get back to the podcast in a minute. I'd like to thank our sponsor, IM8. Now, we as a family like to get 80 to 90% of our macro and micronutrients from a whole foods diet, but I use IM8 to cover the rest. Remember, this is a supplement, not a substitution for a solid whole foods diet. I drink it every day, 1 scoop in cold water, and it tastes great. IM8's got 92 essential vitamins. It's got prebiotics, probiotics, and postbiotics for gut health, MSM for joint health, and CoQ10 for heart health. They've also got these super convenient travel sachets when you're on the go. If you're interested in trying IM8, visit their website, www.im8health.com/London. They're offering a free welcome kit and 5 of these travel sachets with every subscription. Check it out. Let me know what you think. Let's get back to the podcast. All right, so let's dive into the treatment for heart disease. Now, realize on the front end, this is not going to be a all-inclusive, comprehensive review of every treatment of every potential cardiac disease out there. That would be overwhelming and essentially impossible. What I do want to review today are the most common disease processes that I have treated over the last 25 years. And in turn, I think that these will likely be the areas that you may encounter personally with friends and family. And the hope is that this will give you some insight and framework when you encounter these in different situations. So the basic 3 categories that we are going to center on are the same that we actually focused on in the other episodes to maintain appropriate consistency. The first, blockages of the heart arteries or coronary artery disease, problems with the heart valves, and third is electrical abnormalities of the heart. We will explore each of the following areas in each of these categories: medical therapy, where it's appropriate, surgical therapy, and then minimally invasive or catheter-based therapy, again, where that is appropriate in each of these categories. So let's start with the first category, blockages in the heart arteries or coronary artery disease. And just as a brief reminder, this is where there is a blockage or narrowing of the arteries that run on the surface of the heart that then potentially limits blood flow to the heart muscle below that blockage or narrowing. This can result in symptoms of shortness of breath, chest pain, etc. It can also evolve to a full heart attack. So the problem here is maintaining flow to the heart muscle so that there's adequate nutrient and oxygen supply throughout. Well, obviously, if you have essentially normal heart arteries, there's not a lot of need for any type of management. If you don't have any family history and you're very low risk, appropriate lifestyle decisions and maintaining a healthy lifestyle many times is all you need. But what happens to many people is they find themselves in this intermediate or moderate risk where they don't really have any symptoms. They don't really have any blockages based on certain testing, but they still have significant risk factors. And that's where I think people find themselves in a bit of a quandary. Well, what do we do? I don't have any blockages, but I've got these risk factors. Well, the interesting thing is the treatment for patients in this category are not dissimilar to patients that actually do have some symptoms and maybe have some degree of blockages, but not critical blockages necessarily. And that begins with what we call medical management or primary prevention of or extension of coronary artery disease. The mainstay for this is number one, aspirin. How does aspirin work in this case? Well, aspirin inhibits platelet function. Platelets are part of the blood clotting cascade or system. So by inhibiting that, you actually can prevent clots from forming in the heart arteries and thereby potentially decreasing the risk of heart attack. Second is statin therapy. Obviously, a lot of emotion and controversy around statin therapy. I will keep it simple and say this: more lives have been saved with statins than they have caused problems. How can I drive this home a little further? Well, when you think about the term atherosclerosis, the athero part is the cholesterol LDL piece. So without LDL and without cholesterol, there is no atherosclerosis. So it is a very, very important component of blockages in the heart arteries, and statins can really move the needle significantly, driving LDL levels below 100 for the majority of folks and below 70 for folks that have actually had coronary events. The next is something called an ACE inhibitor. And I don't want to get too far off in the weeds, but this is basically a medication that controls blood pressure. It works through the kidneys, through a system that helps to constrict and relax blood vessels, and it actually blocks one of these converting enzymes which allow the blood vessels to dilate, to bring the blood pressure down, and as a result, the heart doesn't have to work as hard for each beat. Now, what are we trying to accomplish with medical therapy? Well, you're trying to reduce the risk of major adverse cardiovascular events, or MACE as it's called. And if you were to fall in one of these two categories, meaning no symptoms, no real blockages, but moderate to high risk, or in fact have some documented blockages, which then of course puts you in the higher risk category, this is the starting point for medical management. So the next layer or next level of treatment is a bump up in what I would refer to as invasiveness. So medical therapy is non-invasive, non-procedural. The next layer would be a minimally invasive decision. From a coronary blockage standpoint, this would involve stenting of the coronary arteries. Now, who would get stented? Let's start there. First, it would be patients that failed medical management and had documented blockages. So patients that were given a trial of medical therapy, but they continued to have symptoms or had progression of their disease process would, of course, be then considered for a procedure to get them out of trouble, if you will. The other group is patients that have significant blockages that are severe enough that the concern is that medical therapy will not be enough to help reduce that risk of major adverse coronary events. So now that we know who needs to be stented, well, what is stenting? What does that even mean, and what does it entail? Well, the more technical term is percutaneous coronary intervention, or PCI. Percutaneous just means through the skin. Coronary means just the coronary arteries themselves, and the intervention is the actual ballooning and the placement of a stent across that blockage. So the way it's done is patients are taken to a catheterization lab, which is the catheterization suite where there's a table and an x-ray machine. The artery is accessed either in the wrist, the radial artery, or in the groin, the femoral artery. A small catheter is then directed under X-ray guidance to the heart into the individual coronary arteries, where dye is then placed into those arteries to determine where the blockage is. A wire is then passed down beyond that blockage, and then a stent, which, if you remember what the old Chinese finger traps look like when you got your fingers stuck in them, they kind of look like that, but they're very, very small, and they are crimped on a balloon very, very tightly so that they can pass through small arteries. That is then passed over the wire, placed across the area of blockage. Then a dye study is repeated to make sure it's in good position. And then when that balloon is inflated, the artery actually expands. It actually cracks the cholesterol and calcium plaque. But then a stent is left behind to protect that artery and keep it open so that when the balloon is deflated, you then reestablish blood flow in that artery. This is typically done with patients awake but sedated. The amount of time that it takes depends on the complexity of the procedure. It's not particularly painful. Patients usually stay a night or two, but depending on how sick they may or may not be, and they recover very quickly. It does require being on blood thinners for a period of time until your tissue is actually grown into that stent and covered the metal itself. Otherwise, it can actually form clot very quickly. So for 6 months to a year, patients are usually maintained on blood thinners. Interestingly, even though this is a foreign body that's put into the bloodstream, because it's a metal that doesn't cause any reaction, there's no risk of rejection or anything like that that would be similar to a transplanted organ. That's a very common question, and I wanted to make sure that I clarify that. So what is the overall success of stenting? Well, it's very good, particularly if the patient selection is appropriate, meaning the extent of the blockage, the length of the blockage, the number of stents that have to be placed or kept to a minimum, and the number of different vessels that are having to be stented is typically kept to 1 to 2, given the patient is appropriate for that particular therapy. One of the most important factors of the overall success in the patient outcomes, and this is going to be a common theme in each of these sections, is, of course, the strength of the heart pump itself. In other words, patients with strong hearts do much better than patients with weak hearts. So when you have patients that are stented that have very, very weak hearts, their long-term survival is not nearly as good as reestablishing flow in patients that either have a normal heart function or that heart muscle is actually hibernating because it's been blood-starved, and once that stent has reestablished that flow, the heart function comes back. Overall, stents are an excellent next-tier option for patients that have failed medical therapy, have very severe disease, and this can be done with very low risk, very little discomfort, with outstanding outcomes with good patient selection. So what if stenting is not appropriate? What is the next layer of therapy, the next layer of invasiveness, if you will, for patients that have blockages in the heart arteries? Well, the next layer is bypass surgery. Let's review who is a candidate for bypass surgery. Well, similar to medical management to stenting to bypass surgery, patients that have failed a course of stenting frequently come to bypass surgery. In addition, there's a population of patients that are just not candidates for stenting on the front end, and they go directly to surgery. Those are typically patients that have what we refer to as triple vessel disease. We have 3 main territories of blood flow on the heart: the front, the side, and the back. And if you have blockages in all of those categories in all of those areas, then bypass surgery has a better outcome long term than trying to stent all of those arteries on the front end. So those are really the two big categories. But what is bypass surgery? What does that even mean? Well, it's got a cute little name. It's called a CABG, C-A-B-G, and that stands for coronary artery bypass grafting. Sounds confusing, but not really when you think about the concept of it. Basically, what we're doing is replumbing the heart. If there's a blockage midway in a vessel, let's say, what we do is we tie in a new tube or conduit below where that blockage is, and then tie the other end to the main blood vessel as it comes out of the heart, the aorta, to actually bypass around the blockage to bring high nutrient, high oxygen blood flow to the heart muscle that's down below the blockage. So essentially, we don't remove the blockage, we bypass around the blockage. Now, what does this operation entail? There are two options for approaches as far as incisions are concerned. The standard old zipper incision, like we've all heard about, it's called a median sternotomy or midline sternotomy. The second is a minimally invasive approach that involves a very small incision just under the left breast or left pec muscle in between the ribs on the left side to access the heart in a very minimally invasive way. There are certain patients that are in fact candidates for that. The majority of bypass surgery is done through the incision down the middle of the breastbone. Now, how do we do the bypasses? Where do we get the tubes from? One tube that we use 90+% of the time is the mammary artery or internal mammary artery. And it basically is a blood vessel that lives behind the breastbone on the left-hand side. And what we do is we actually separate that artery from the back of the breastbone. We disconnect it from one end, the end that the blood's going to come out of, so that when we tie that into the heart muscle, we're taking an artery to an artery. And we'll talk about why that's important in just a minute. The second place that we typically get conduit or tubes from is from the saphenous vein in the leg. Now, we remove this typically just with a scope. We have to make a small incision at the knee, one at the groin, and we can typically take out the entire vein. We don't have to make a long incision in the leg anymore to take it out. Patients honestly complained more about their leg years ago than they did about the chest incision, because every time they would take a step, it would pull so badly, and that's essentially non-existent now. So we typically use the artery that lives behind the breastbone on the left-hand side to go to the important artery on the front of the heart, which is the one that controls the big pumping chamber. That we have an artery to an artery, and then we use vein to go and do the remainder of the bypasses. If the patients are younger, we typically look for other arterial conduits, in other words, similar to the artery that lives behind the breastbone. And the next most common place would either be the mammary artery on the other side, or actually removing one of the arteries from the forearm and utilizing that. Now, why would we use arteries versus veins in younger patients? Well, if you think about it this way, we're going artery to artery when we're using the mammary artery or others. When we're using a vein, we're actually asking a vein to do an artery's job. So when we look at the long-term outcomes of how long bypass grafts last, artery to artery lasts typically 12 to 15 years. Vein grafts last 10 to 12 years because they become thickened over time and just are not nearly as durable, and we're asking them to do a job that they actually weren't designed to do on the front end. But we typically make that decision in younger patients because if they're overall survival is not going to extend beyond that, the additional bypass grafts utilizing the arterial conduit typically doesn't make much sense. In addition, there's several ways to actually do the bypasses. Most commonly in this country, we use the cardiopulmonary bypass or heart-lung machine, which takes the deoxygenated blood back to a machine. It places oxygen into the tubing, and then we put that back in the body. This enables us to stop the heart and allow blood to continue to circulate while we're doing the operation, and we're operating on a very still, non-beating heart. And that's how the majority of the operations are done in this country. The other option is beating heart surgery, where we actually leave the heart beating. We do not use the heart-lung machine, and we have stabilizing devices that they have small suction cups on them is how they work. They look like small octopus tentacles that then hold the blood vessel in position while we do the bypass, while the heart beats around that device. It really becomes surgeon preference, which method you utilize. I use both depending on the clinical scenario. When we look at the large clinical series, the outcomes difference, if we look at large series, are not much, there isn't much discrepancy there. In higher risk patients, however, utilizing this beating technique and avoiding the heart-lung machine, or sometimes using it in combination with the heart-lung machine, but not stopping the heart, gets us a great deal of benefit. So there's a lot of middle ground with how this is done. As far as the goal of the operation, it is identical to stenting, and that is to restore blood flow to an area of the heart that is blood starved. Not doing it from the inside of the artery, but actually bypassing around the blockage. What is the single most important determinant of how people do, not just with the operation itself, but long term? Once again, it's the strength of the heart pump that determines short-term and long-term survival. We'll get back to the podcast in a minute. I'd like to thank our sponsor, 8 Sleep. This has to be the most important addition to my health and wellness routine over the last year. Sleep is so incredibly important, and I struggle with sleep, particularly when it comes to temperature. You can easily add the 8 Sleep cover to any size bed. And over here on the side of the bed is where the 8 Sleep pod sits. This is the brains of the system and where the water is contained. You can independently heat and cool either side of the bed. I like it cold, my wife likes it hot. In addition, it tracks all of my biometric data without any wires or wearables. Heart rate variability, resting heart rate, respiratory rate, as well as all of my sleep stages. In the morning, all of the data is available on my phone. I recommend the 8 Sleep to all of my family members and my friends. I truly love it, and I've come to depend on it. If you're interested, visit the website at www.8sleep.com/London. Use code London at checkout for a discount. Now let's get back to the podcast. What are some common themes that run through both of these treatment modalities when we look at them from 20,000 feet, if you will? Well, the first is that the goal of both of them is to solve a plumbing problem, and that is to get blood flow to an area of the heart that doesn't have adequate nutrient and oxygen. The important thing to take away from this, however, is this gets the patient out of trouble, whether it's stenting or bypass surgery, but it does not address the underlying problem of the hardening of the arteries, which is why stents and or bypass surgery may not last forever. It may be 10 to 12 years. It may be 6 years. It may be 15 years. Because if you have a stent and down below that stent, there now is a new blockage, then that's going to affect the flow through that stent. If you have a bypass graft that's plugged in a certain area of the artery, it may have been below the blockage that was there 3 years ago, but now there's new blockages. So undergoing these procedures, albeit a second golden ring, if you will, to get some quality of life and longevity back, It doesn't treat the underlying pathology. In addition, heart function is critical to outcomes for both of these. Remember, patients with strong hearts do much better than patients with weak hearts. Because the underlying pathology is not treated with stenting or bypass surgery, with both of these, lifestyle modification is absolutely critical. For instance, when I talk to a patient before heart surgery and they're actively smoking, I explain to them that I'm not going to soapbox them about stopping and quitting, and I know how hard it is and I know how difficult it can be, but they have to understand that if they continue to smoke on the bypass grafts, all bets are off. It's not necessarily 10 to 12 years or 12 to 15 years. It could be 6 months. A solid whole foods diet, exercise program, following a medication regimen, all of those things put together are what make a difference in long-term outcomes when related to blockages in the coronary arteries. And finally, as with any procedure, the choice of procedure is always based on the risks versus the benefits. You always want the benefits of the procedure clearly to outweigh the risks. Let's make a slight shift from the outside of the heart, which is where the heart arteries live, the coronary arteries live, to the inside of the heart and look at problems with heart valves. Now, diseases of the heart valves come in two flavors. They're either blocked or stenotic, as it's called, or leaking or regurgitant, if you will. Therapy is directed accordingly. For a blocked valve, it's relieving that obstruction. And for leaking valves, it's resolving to and fro flow of blood in and out of the heart. Valve problems are most accurately diagnosed with something called an echocardiogram, which is simply just an ultrasound machine, very similar to what's used during pregnancy. A small probe is placed on the heart, and we can actually get very clear images of the heart valves and their functions, and then can actually examine the flow across those valves to determine if there's a problem. Now, just because you have a heart murmur as a result of a diseased valve, or just because you have a valve problem on echo, doesn't mean that you have to have an operation, because there is a wide range of severity of valve problems, ranging from mild to moderate to severe. Secondarily, whether or not these valve issues are actually causing problems such as symptoms, all get put into the bucket to make a final decision about how you're going to be managed. Let's talk about aortic stenosis first, or a blocked aortic valve. Now, the aortic valve is the main valve coming out of the heart, out of the left ventricle, the main pumping chamber, driving oxygenated blood to the entire body through the main blood vessel, the aorta. Well, as that becomes blocked, obviously blood flow is restricted, the heart's having to work very hard. But again, remember, there is a range from mild to moderate to severe. And based on symptoms determines whether or not patients are candidates for operation. Mild to moderate, no symptoms, usually close follow-up. Severe, no symptoms, let's apply our three categories. We know that natural history of a severely blocked aortic valve is worsening of heart function, symptoms, and potentially even death. So they fall into changing the course of the natural history of the disease process. The risks of doing nothing in that case far outweigh the risks of the operation to replace that aortic valve. Patients with severe aortic stenosis and symptoms, although they're not actively dying, they are actually at a 20 to 25% risk of sudden death. So the risk of death and the constant fear of the possibility of sudden death is so high that, again, moving forward with operation seems only appropriate. Just to give you an example of how we apply those categories in a real-life situation. So what is the treatment plan for patients with aortic stenosis? Well, this is a structural or architectural problem within the heart. And although there are medical therapies that can help temporize or potentially bridge to operation, there's no medications that are going to actually change the structural abnormality. And so this requires valve replacement. And there's a couple of different options. So we'll start with the standard open operation, again with the incision down the middle of the breastbone, and then stopping the heart on the heart-lung machine, opening the main blood vessel, removing the patient's existing valve, and then sewing in a new valve. The next question, of course, is, well, what kind of valve? There's two types of valves. Two choices. The first is a tissue valve. That can either be from pig or from cow pericardium that's then sewn on a metal strut system to create a new aortic valve. This is referred to as a tissue valve or a bioprosthetic valve. Keep in mind that these tissues are what we refer to as denatured or put into formaldehyde-like solutions that fix these tissues. So again, there's no risk of rejection or your body finding something foreign like pig tissue in the heart and rejecting it. That doesn't happen because of the denaturing process. The second valve choice is a mechanical valve, which is a carbon fiber valve. There are advantages and disadvantages to both, and we will go through these. The tissue valve is durable to a point. They typically last 10 to 12 years, but then have to be replaced. And either they can be replaced through another incision or potentially through a more minimally invasive approach, which we'll talk about in a few minutes. The upside to the tissue valve is it does not require any blood thinners for life. On the other hand, a mechanical valve will outlive all of us because, again, it's carbon fiber. But to maintain that function, and because it is a what we refer to as thrombogenic or potentially clot-forming environment, it does require that the patient takes Coumadin or blood thinners for the rest of their lives. So who gets which valve? Well, typically patients 65 and less, we push towards mechanical valves. If you are over the age of 65 or you have some reason that you can't tolerate blood thinners and you're younger, then we recommend tissue valves because, of course, if you do the math, if you're 55 years old and we put a tissue valve in, that only gets you to 65. And you're already on your second valve, and that gets you to 75. And so we're almost condemning you to yet another procedure if you put a tissue valve in when you're too young. Now, there's reasons in different situations why we may choose one or the other, not based strictly on these guidelines, but those are kind of the rough guardrails as far as the decision making. The operation to replace an aortic valve typically takes about 3.5 hours. Patients spend anywhere from 3 to 5 days in the hospital, and it's about a 3-month recovery start to finish to really be back up to speed. The other option is a minimally invasive approach to the aortic valve, which is basically a small incision in the upper right chest and then a small incision in the groin because we can't access the blood vessels to go on the heart-lung machine directly. We have to use the artery and vein going to the leg to do that. We can actually replace most aortic valves through this minimally invasive approach if it's something that you have been trained to do. I've been doing that procedure for the last 15 years, and it really has been a transformative step for patients that have to have an open operation for replacement because it really decreases recovery time. pain and discomfort, and they don't have to worry about the healing of the sternal halves as they go through their rehab process. The other option for aortic valve replacement is called a TAVR procedure, or transaortic valve replacement. And this involves going through an artery in the leg, the femoral artery, under X-ray guidance with a valve, much like the stent, loaded on a balloon. It's a tissue valve, not a carbon fiber valve that you could not load on the balloon. So these are all tissue valves to go across the valve under X-ray guidance and then expand that balloon. And when the balloon deflates, the valve starts working immediately. Now, this procedure, quite honestly, has transformed our ability to replace aortic valves with very low risk, very low morbidity, and very little recovery time. We do this procedure essentially with the patients sedated but awake, with local anesthesia in the groin. It typically takes about an hour, hour and a half. And assuming no bumps in the road, patients spend a night in the hospital. They go home the next day. They have to take it easy for about a week. And after that, they have absolutely no restrictions. Now, who gets a TAVR valve? Well, it's a tissue valve. So by definition, anyone under the age of 65, unless they can't tolerate a standard open operation, should not be considered for this procedure. But anyone over the age of 65 is certainly an appropriate candidate for evaluation. And it is really becoming consumer driven these days in many respects, because who wants a really big incision on the chest when you can have an hour-long procedure under local anesthesia? Continuing with problems of the aortic valve, next is a leaking, or what we would call a regurgitant aortic valve, where instead of being blocked, the valve leaflets are not coming together properly for a variety of reasons, and blood actually is backing up into the pumping chamber with every beat as the heart relaxes, whereas normally it would continue moving in a forward direction. So instead of the situation with a blocked valve, where the heart muscle is working very hard and getting thicker and thicker, and the cavity is getting smaller, and over time that can potentially fail, it's a little different scenario with a leaking aortic valve, because the heart is becoming very, very swollen over time, and the heart does not like to be swollen over time. And once those fibers get stretched, the heart will become markedly weak, and of course the risks of operation go up dramatically. When it comes to the decision making of who gets an operation, it's very similar. It's based on severity of leakage, mild, moderate, and severe, in addition to whether or not the patient is having symptoms or not. The actual operation is identical. It can involve the incision down the middle of the breastbone or the small incision to the right side. And the valve choices are the same, either the mechanical valve for patients under the age of 65 or the tissue or bioprosthetic valve for older patients. Now, interestingly, there is a TAVR or percutaneous valve option that is currently in study, but it is not widely available, so we don't really have that option for leaking valves right now. And the reason that there's a difference is when you have a blocked valve, there's typically calcium associated with either the leaflets or the ring of the valve. And when we expand that balloon, that TAVR balloon, the calcium actually becomes the anchor point to hold that valve in place. With the leaking valves, sometimes there is calcium, and we have done TAVR valves for leaking valves when it's kind of a mixed picture of blockage and leakage. But in a purely leaking valve, there rarely is anything to anchor onto, but the newer valves have, in fact, devised a method of anchoring the valve in place so that it can be done through the groin. Continuing with this theme of a leaking valve, but shifting now from the aortic valve to one of the other common problems that I see in practice, the mitral valve leaking, which is the valve that's in between the upper chamber on the left side and the left ventricle. Again, these are diagnosed with echocardiogram and range anywhere from mild, moderate to severe. The decision making is typically based on which category patients fall into and whether or not they are symptomatic. It is important that, again, with these leaking valves, that we recognize when there's either progression or it's already in the moderate to severe category, but the patient doesn't have symptoms, that we intervene early, again, to prevent that swelling of the heart, particularly with this valve, because you get swelling of both chambers many times, and that can be real problematic, and we will talk about why in just a minute. As far as medical therapy for a leaking mitral valve, again, this is a structural problem. Intensification of medical therapy for mitral regurgitation is certainly something that makes a significant difference with patient symptoms. But again, it doesn't treat the underlying problem. It certainly temporizes them very well to get to an operation, or potentially flattens the curve of how long they can wait until that operation actually happens. As far as the approach for many patients with mitral regurgitation, particularly younger patients, the goal is mitral valve repair, trying to actually maintain the tissue that exist with their God-given mitral valve before having to make a decision about replacement. There are multiple different approaches to operation for the mitral valve, not dissimilar to the aortic valve, again, through the standard midline incision. We also can do minimally invasive mitral surgery, which is how I do the majority of mine, which is actually through a small incision just under the right armpit, if you will, and a small incision in the groin to go on the heart-lung machine. In addition, this is one very, very good application for robotic surgery, although the robotic incisions probably end up equaling the single incision that I may make underneath the right arm. There are advantages as far as visualizing the valve and some other things as far as the robotic experience, but there are only certain centers in the country that are doing this with any level of regularity. As far as making a decision between whether or not we replace or repair the valve, we can usually have a pretty good idea based on the echocardiogram before surgery. What typically happens is if the mitral valve is like two parachutes that come together in the center, almost like a Roman arch, and they're held together by the strings of the parachute down below. Well, if one of the strings of the parachute breaks, then a portion of that leaflet is no longer coming together like the top of the Roman arch, and as a result, that valve starts to leak. So how do we repair that? We can actually recreate that line of the parachute by creating something called a neocord or new cord to hold that valve, and then placing a ring around the valve surgically to take the pressure off of that repair that brings those valve edges together. Many times we can't make the final decision about repair or replacement until we get in there and actually look at the pathology and what level of tissue we have to work with. Again, in younger patients, younger than 70 typically, I try to repair the mitral valve. In patients older than that, if it's very, very straightforward, then I may give it a shot of repair. If not, I typically replace the valve. Again, the valve choices are exactly the same: the tissue valves, pig or cow, or the mechanical valve, depending on age. What's the downside to repair? Well, there is a 10 to 15% failure rate at 2 to 3 years of repair. And the reason for this is when you have resuspended that valve tissue, you can get scarring along that area, and that can become trapped over time. It doesn't happen to all patients, but 10 to 15% is not an insignificant number. For me personally, unless the repair is 100% as perfect as I can make it, I actually replace the valve. So for me, my failure rate is a little bit lower than the national average, but my replacement rate, in other words, deciding not to repair and replacing the valve, is slightly higher. But I'd much rather replace a valve than have a valve fail and have to repeat an operation in 2 years. As far as catheter-based options for mitral regurgitation, the most popular one right now is called MitraClip, or a clipping of the mitral valve. And again, think of that two parachutes coming together and one piece of it is not actually attached. Well, through the groin, under x-ray guidance, a catheter can be placed at the mitral valve where the leaflets can be grasped. One grasper on one leaflet, the other grasper across the road, if you will, on the other, and we actually clip the two leaflets together so that the valve then stops leaking and becomes competent. It's a great procedure for patients that can't tolerate an open operation. The length of time that it takes can be anywhere from an hour to 3 hours. Again, it's a night in the hospital and the recovery is minimal. There are percutaneous or catheter-based mitral valves that are currently undergoing clinical trials that should be released soon, but they are only available in certain centers. So a quick recap on valve problems, both of the aortic valve, blocked and leaking, and the leaking mitral valve. These are all problems that are happening inside the heart pump itself. They are structural problems within the heart that typically are not fixed with medicines. The goal of the operation is either to release the blockage and release the tension on the heart muscle, or to resolve the leakage of blood and prevent the swelling of the heart chambers themselves. And finally, catheter-based valve replacement and valve interventions are truly going to be the future. So let's shift gears a little more significantly here, also remaining on the inner workings of the heart, but looking specifically at problems of the electrical system. And diseases of the electrical system, to simplify it quite a bit, fall into two categories: either fast heart rhythms or slow heart rhythms, and then a subcategory of whether those are regular rhythms, regular slow rhythms, or regular fast rhythms, or very irregular rhythms. The most common electrical abnormality that we see is atrial fibrillation. Probably have all heard this term at some point. You have an aunt or uncle, or you yourself might suffer from it. But this is the most common electrical abnormality that we come across. And what is atrial fibrillation? Atrial fibrillation is where the top chambers of the heart are beating in a very discoordinated fashion, typically very fast, and they are not communicating directly with each beat with the lower chambers of the heart. So you have this very disorganized rhythm up top, very inefficient, and a very irregular rhythm down below. Well, why is this really a problem? I mean, well, first is that it's disorganized, and that then makes it a very inefficient way for the heart to work. So what are the goals of therapy with atrial fibrillation? Well, ideally would be to get patients back into a normal sinus rhythm. That happens a certain percentage of the time based on some of the therapies that we're going to talk about. But many times it's just a matter of trying to control the heart rate so that the heart has a chance of working more efficiently. In addition, with atrial fibrillation, because the upper chambers are not pumping efficiently, blood stagnates in certain areas of the heart, which can cause clot inside of the heart, which can then be flipped out into the vasculature, and there's about a 20 to 25% lifetime risk of having a stroke when you have atrial fibrillation, which is why blood thinners are typically part of the medical regimen for atrial fibrillation, particularly in the initial management. So if patients don't respond to medical therapy, or they can't be on blood thinners, or there are a variety of other reasons, what is the next layer of evasiveness? Well, that would include catheter-based ablations of the electrical pathways. What does all that mean? Well, it means accessing the blood vessels, typically in the groin, under X-ray guidance, going to the interior of the heart now, and actually performing electrical mapping of these disorganized pathways real time, and then creating what we refer to as lesions. But what they are is essentially either very low-level burns or freezing of the cardiac tissue from the inside to help block these reentrant pathways, creating this very disorganized heart rhythm in the top of the heart chambers. Ablation with the right patients is very, very effective. It can certainly result in conversion of patients to normal sinus rhythm, which is the ultimate goal. In and of itself, ablation does not address the stroke risk. From a catheter standpoint, the way that is addressed is through something called a Watchman procedure, which looks like a wound bird's nest of copper wire, if you will. It's not copper, but it looks like a wound ball of copper that is tightly constricted in a catheter, and then under X-ray guidance, once again, is directed towards an area in the left atrium called the left atrial appendage, which is where these clots come from. This device is then placed into that section of the heart to prevent clot from forming there, or to prevent that area from becoming a problem long term. There are surgical approaches to deal with ablations as well. We frequently will do ablations on the outside or surface of the heart if we're there doing bypass surgery or valve surgery and patients are in atrial fibrillation on the front side. In addition, we can actually put a clip on the left atrial appendage from the outside when we're in the operating room. That prevents there having to be any foreign body left in the actual heart, like a Watchman, although both are very successful. So there are both interventional or catheter-based therapies for atrial fibrillation, in addition to surgical therapies for atrial fibrillation. What about slow heart rates? Well, this category is a little simpler in that the treatment typically is, number one, making sure that patients are not on medications that are causing the heart rate to be slow, and making certain that they don't have other diseases or metabolic processes that are causing like abnormalities in electrolytes or hormonal changes that may be causing low heart rates. It's typically diagnosed with a EKG or potentially with a Holter monitor, which is actually worn at home over a period of time to pick up any slow heart rates. The treatment for slow heart rates, be them either symptomatic or not, depending on how slow they are, is pacemaker implant. There's two types of pacemakers. There's one that has a small battery that's placed under the skin, and two wires under X-ray guidance are placed in the heart, one on top and one down below, and then it resynchronizes the heart. It actually can sense the amount of activity that you're under at a given time, sitting versus getting up and going to the refrigerator or going to the bathroom or taking the garbage out, and actually will speed up and slow down your heart rate based on your activity level. There's also a fully implantable pacemaker that's wireless, that works very much in the same way. It has some limitations, and there's benefits and drawbacks to both of these. They're typically both placed under local anesthesia, take less than an hour to do so, and can usually be an outpatient procedure. Now, again, common theme when we're talking about heart rhythm issues that you have then heard previously, and that is inefficient heartbeat with fast heart rates like atrial fibrillation result in inefficient hearts, heart failure, decrease in heart function, increase in risk of death. Slow heartbeats, if not treated properly, result in a decrease in the amount of blood that's being ejected from the heart over time. It can also cause significant symptoms of passing out or even sudden death. But over time, the slow heart rate will result in a dilated ventricle that will eventually weaken and increase risk of death. So all of these things, as different as they are, from blockages on the front of the heart to a blocked valve to a leaking valve to an electrical problem, all kind of point to one particular North Star when it comes to indications for operation. And that is to increase lifespan, increase health span and quality of life, but most importantly, to preserve left ventricular function or the strength of the heart so that all of these other things can fall into place. But one of the things that you truly need to understand is that these procedures in and of themselves are not going to move the needle alone without being fully engaged in this process with appropriate lifestyle changes and good dietary changes and following medical regimens and appropriate follow-ups with physicians, etc., and full engagement in this process for you to get the full and maximal benefit of any of these procedures. Just as I mentioned early on, bypass surgery does not address the underlying problem. So in and of itself, that's not going to get you where you want to be. It's a matter of taking responsibility for your own health care so that you can get the most out of these procedures should you need them. If you have made it to this point in the podcast, thank you so much for your time. If you have been watching on YouTube, please like and subscribe. We certainly would appreciate the support. If you are listening on Spotify or Apple Podcasts, you can leave up to a 5-star review, and we would be so appreciative. I hope you guys have enjoyed, and I hope you guys have a great day.